Welcome back to Mapping Healthcare on KDRT 95.7 FM in Davis, California, where a medic with a map explores healthcare around the world, highlights people who improve it, and shares what we can learn from them. This is your host, Dr. Sheikh. Behind so many of our children with complex medical needs, there's this huge, often invisible support system. We're talking about a network of parents and family members who do so much more than just parent. So in today's episode of Mapping Healthcare, we're going to try to understand the reality of caregiving. In the words of a parent of a child with medical complexity, it's not just about parenting. It's about becoming an entire medical team, a doctor, a nurse, a therapist, all rolled into one person. The people we're talking about today are caregivers for children with medical complexity. So what does that term children with medical complexity mean? We're talking about kids with really significant chronic conditions. They often rely on medical technology, things like ventilators or feeding tubes, just to get through the day. And all of this leads to a ton of healthcare use, an absolutely enormous demand on their caregivers. And that demand, it's not a single challenge. It's a cascade of barriers that touches every single part of a caregiver's life. Those areas are all connected: the personal, the family, the social, and the financial. Let's start with the personal impact, and this goes deep. It's about the very core of who you are. This role can completely change someone's identity, not to mention their physical and mental health. Parents share the immense mental toll, profound burnout, and a deep sense of isolation that this can lead to. A feeling that you're completely and utterly alone in this. And then, of course, there's the financial impact. We're not just talking about medical bills here. It's the lost jobs, it's the therapies that insurance won't cover, and all those hidden costs of making your home or your car accessible to your child's needs. The need for constant close supervision often means giving up a career or other opportunities. But the impact doesn't stop there. It radiates outward and can affect the whole family, the social circles. Your lived experience is so different, so intense, that it becomes almost impossible to relate to family or friends who just haven't walked in your shoes. Our guest in today's episode of Mapping Healthcare is pediatrician Dr. Helen Leonard. She's a consultant in pediatric neurodisability in England and a mom of 3 children. I first met Helen at a conference where I heard her talking about her lived experience navigating the healthcare system with her son Matthew. The views expressed on this show are mine and those of my guests. Hi, Helen. Thank you so much for joining Mapping Healthcare. Today is a special day because I'm talking to a fellow pediatrician. You are a pediatrician and a specialist in pediatric neurodisability in England, and you're also a mom of 3. And one of your children, Matthew, is a young adult with complex disabilities. So let's start by you're telling us a little bit about Matthew's medical journey.
Hi, thanks for asking me along. So Matthew was born with very complex disabilities. To me, it was really apparent by day 2 that there was something radically wrong. And in hindsight, he had cerebral irritation. Took a little while to get people to listen to me. He was my second baby. I was a pediatrician, so people should have listened. But I heard all sorts of things about, oh, he's a big hungry boy and your first one was a girl and they're different. Anyway, that went on for a short while. And by 6 weeks old, we'd had his vision tested. And there was an acknowledgement that at that point he had some visual impairment. And then by 3 months old, there were more tests coming back and he wasn't making developmental progress. And there was clear that there was something much more to things. And then when he was around about 6 months, he started having seizures every day. And he's continued to have seizures every day, despite lots of attempts at treatment until to date, really. And he's now 25. And so he has a very complex disability, has a profound learning disability. He's a wheelchair user, so he's not able to stand, walk, and he doesn't have good sitting balance either. He has epilepsy and he has a scoliosis now, very significant scoliosis. So he's in that group of children that are hard to define, but we all recognise as having profound intellectual disabilities and medical difficulties as well. So sometimes termed children of medical complexity, a group that's difficult to define, but we all recognize them when we see them. And we know, in our pediatric world that they are probably a smaller group of children, but occupy a huge amount of pediatrician and hospital time and resources and are very frequent visitors to the hospital.
Yeah, and you've had a lot of experience with the UK's National Health Service, both personally and professionally. So
Yeah.
you've worked as a healthcare professional at the NHS since 1993, and you've received services through the NHS since Matthew was born in 2000. So your experience with your son has influenced your life personally and professionally quite clearly. So what are some of the things one doesn't realize being a pediatrician about being a parent of a child with long-term complex needs?
Yeah, so that's a really good question. We could spend the whole podcast talking about this. So I'd been in pediatrics for 6 or 7 years by then, and I don't think I was ever unsympathetic in any way, and probably was, as kind and understanding to families as anybody. But it was such a shock to the system being on the other side of it and having a child where we were gradually discovering there was something very, very serious wrong with him. And it was the utter devastation. I'd watched families and I'd said, I'd even said to people, gosh, that must be the worst thing that can happen to you. But I still had no idea the utter devastation that I felt as a mum, realizing that there was something seriously wrong with your baby. And I think because we deal with it every day, and I'm a pediatrician as well, and I see it. I think we just don't acknowledge sometimes emotionally what families are going through. And, sometimes families are labeled as difficult or whatever, but I always have to take a step back and remind myself that, no matter how stressed or how we're feeling, we'll never have an understanding of that emotional hit that people take when their child receives a big diagnosis. Another thing I didn't realize is the loss of control over your life. And I think that sometimes underpins some of the conflict that families can get into with professionals. So an example of it, on Friday, I was travelling back from a work journey. It was a plane flight and the plane was delayed and we weren't being given information, and you can't do anything. You lose the control. And we all get a bit stressed and unhappy and, with delays and rerouting and stuff. So we've kind of all been through that and we can acknowledge that. And that's just a trip home. And it lasts for a day or two and then you sorted. But that's really because you've lost control. You can't make decisions. Things aren't going to be how they're meant to be. And that's what happens when you have a child with medical diagnosis. But it's not just that one day or that 2 days, it's the rest of your life, really. And you just lose control about, what you'd planned to do, some of the decision making, things that you'd hoped was going to happen in your life. It's kind of taken away from you. And it's a huge adjustment. And I think sometimes services often end up telling families what they need to do rather than having a conversation and a more balanced approach about what will work for you, what will you need. And also, because of the level of care Matthew needs, we've had involvement both with healthcare and with social care to try and get support at home because he needs 24-hour-a-day care. And all of that's incredibly intrusive. Your family privacy and your right to a sort of family life absolutely goes out the window. And that's really tricky to deal with as well. And, you see things written in medical reports and social care reports and all sorts. And they want to know lots and lots of information about your family. And, I dutifully handed all over that when this whole process started. And as the years have gone on, I've sometimes sat there and thought, how is this relevant? Matthew has horrendous epilepsy. He fits every day. Why do you need to know about his grandma or, his auntie, or where it's like it's irrelevant. He's somebody with needs. So I think we need to be a little bit careful about professionals. I know we all do, it's relevant, somebody's social and family circumstances, and we all take our good family social history, developmental histories. But I think we've got to be a little bit careful about, do we need to know this? Are we just doing it for the sake of it? Is it actually intrusive? Because when you're on the other side of it, you see reports about yourself written down and it's quite a surreal experience. And I think sometimes the information's used very carelessly and staff can gossip about families as well. And it's really not right. And again, it's coming back to, well, if I was in their shoes, would you really like somebody saying this about me. And, people know what you feed your children because that has to go in reports and everything. So those things that you probably take for granted in your day-to-day life are suddenly gone. So the control and the right to a private family life. And, for us, we've had, since Matthew turned 17, he had care at home. He left school and had a care package at home, which has been brilliant. But it's also meant I've had carers in my house every day, some of whom are amazing and some less so. But that's quite intrusive as well. And there's people in your family home. And luckily, we've been given a budget to employ people ourselves. But had we not done that, we would have had a whole string of strangers sort of arriving at our front door who we've got no control over, we've never met before, coming in to look after your child. And we certainly had some experience of Matthew as a child with agency care coming in. And, normal families with a healthy child, if a random stranger arrived at your door, you wouldn't let them in to look after your child. But when you have a child like Matthew, that's what happens. So it's some of the things you go through are quite tricky.
Yeah, and you spoke about so many challenges there, Helen, and the large amount of information we collect, a lot of it irrelevant to the person's needs. And you spoke about the loss of privacy, the vulnerable situation that families are put into, which then brings us to this issue that health systems are generally better at handling single issue fixable conditions and heart attacks, trauma, but they usually fall short for families like yours who have people with complex
Yeah.
multifactorial needs. So in your opinion, what are some of the root causes of these suboptimal experiences that your family has had?
You've touched on it there. I think it's kind of silo-based services. So if, Matthew's been referred to lots of services like orthotics, like wheelchair services, physio, hundreds probably by now. And every service will say, this is what our service does. And I don't think in 25 years anybody has actually sat me down and said, what is it that would help you? What is it that you need? It never starts with your needs. It starts with what services offer. And because Matthew is, even for somebody with complex disabilities, he's unusual. He doesn't have cerebral palsy. So often, especially the school he was at, they very much understood children with cerebral palsy, but his pattern of difficulties are different from that. And because of that, they were aiming things wrong. And that often happens. If you don't fit neatly into a service box, then it's really hard to get the services that you need. And they often don't join up. And I think also it's about seeing our family as a whole and the family function. So a really good example I often talk about is my dad died when Matthew was about 5. And my dad had been totally fit and healthy, developed cancer, had metastases at diagnoses, and died within 4 months. And he came to my house to die. So I was working, I had a 6-year-old. Matthew was disabled at 5 with high needs, and a 1-year-old. And I had a terminally ill father. And I rang everybody, cancer services, district nursing, trying to get more help to Matthew, saying, look, somebody's got to help us. But everybody said, oh, we do pain control and whatever for dad. And I said, but I need somebody to actually come in and get my dad washed and dressed. Oh no, we can't do that. And so everything was looked at. Dad's need, everything was looked at individually. Nobody looked at us as a family going, oh my goodness. And then in the middle of all of that, my father-in-law at the time was living abroad away from us and had a stroke. And my ex-husband got on a plane to go and be with him, which was quite right. So I was then left as a single mum dealing with all of this. I'm just trying to do my work as well. But so nobody looked at the bigger picture. It's very centered on how services are structured rather than people. And we need to move away from that. And I think another thing health services do, you touched on, we're brilliant at some things. So intensive care, hospital-based care. So if we'd wanted a gastrostomy, or if it was the right thing to have Matthew's scoliosis fixed, that would be picked up by the health service. And it would cost tens of thousands of pounds for both of those things. But actually, they're not right for Matthew. We then balk at sort of much cheaper things like a better wheelchair for him, which would completely change his life and would cost far less than a gastrostomy or scoliosis surgery or lots of other things that we could have, but it's not right for him. So I think there's something about spending on very visible acute hospital-based things versus spending on community care that most health services don't wrap their heads around, but actually it would make a much bigger impact on people's lives.
Yeah, and you are a member of NHS England's strategic co-production group, and some of what you just mentioned really is at the heart of what's co-production done right. So as part of the group that you work with, you've worked with families to involve them in decisions. And what you described just now is this tendency of healthcare systems to take a paternalistic prescriptive approach to what people need instead of starting off by asking them,
Yes.
what are your needs and what's important to you? Let's now talk about a program that NHS England has that gives families with children with special needs a personal health budget. It's basically an allowance to purchase the care and equipment that they need. So, really putting families telling you what their needs are front and center.
Yeah.
Tell us about how a personal health budget, as opposed to standard care, made more sense for your family.
I would have to say it was life-changing. Absolutely for Matthew. Where we were at when he was in his teens, he was needing a higher and higher level of care. And we were constantly fighting for scraps of care. You know, we needed a different wheelchair, we needed more support at home, just practically looking after him. But all the services were different. So we're dealing with lots of different people. The frustrating thing is, you know, social care wanted him in education more because basically then they wouldn't have to pay for it. It would come out the education budget. And education was saying, but, you know, he's not learning anything, which I totally agreed with. What's the purpose of him coming to college? What's he actually going to get out of it? And I went, I totally agree, nothing. I remember a meeting between health, social care and education, and it felt like those air hockey pucks on a table where you have a sort of thing and you bat it to the table and it pings all around, then another person hits it and it gets pinged. And we felt like that puck in the middle being bounced between services because everybody knew his high needs and nobody wanted to pay for it. That was the bottom line. And what I said is, look, Matthew doesn't need big fancy services, or he basically likes to be outside all day long, whether it's wind, raining, snowing. He likes fresh air, he likes sensory experiences. That's the level he functions at. If he's in the fresh air, he eats and sleeps well, he has less seizures, and he's happy and calm. If he's inside a big, busy college, he can't see and hear properly. He's registered blind. He gets very distressed. He doesn't like it. He doesn't learn anything. He gets nothing out of it. It's not suitable. So it wasn't like I was asking for, you know, a gold-plated wheelchair. I just wanted a wheelchair that was robust enough to take him out and carers to take him out for several hours a day. The school placement was, you know, tens of thousands of pounds a year, and I didn't. I wanted carers at home to push him in a wheelchair. And the battle I had to get that was ridiculous. And it was eventually solved by getting a personal health budget, which meant that essentially the money was given to us. So they started off, they've been around in the UK since about 15 years. There was a pilot done, evaluation, which included financial evaluation of them. And they have been around since. And interestingly, we've had big political government changes, different parties. And I think people were worried that as soon as one government came in, they'd be gone. But actually, they've survived several government changes and the commitment to keep them and expand them, in fact. And the reason is they work very well for very complex people about giving them good care and keeping them out of hospital because it's tailored. And the initial evaluation, I think, was if you give somebody a personal health budget, I think it was a 17% saving to the health system in terms of reduced cost. And for people like Matthew, who are high needs, it's even more. And it keeps them out of, you know, hospital as well as delivering better care. So our own experience was at the time he got it, he was very underweight. So you're a pediatrician, you'll understand this. It was 5 kilos off the bottom of the centile chart. And that was the stage we were discussing a gastrostomy. And he was very distressed a lot of the time. And he was needing multiple people to often transfer him because he was very distressed. Basically, once we got him home and he was in a quiet environment on his own, being outside a lot, he started eating, he was calmer, the transfers became easier, he slept better at night, he had fewer seizures. He put on 18 kilos in 18 months just from being fed nice home cooked food at home by carers that knew and understood his feeding needs in a quiet environment. That's all he needed. He didn't need a gastrostomy. I can understand, you know, looking at his chart and looking on paper, that's what it looked like he might need. But actually, he just needed care that was meaningful to him. And he's been so happy since he came home. We actually had a workman to the house that was involved in doing some work before when he was still at school and came back about 4 or 5 years later. So he's just a builder, was plastering the walls. And he remembered Matthew because he's quite unusual. And he said to me, gosh, he's so different. He said he was all chewed and he was all upset last time I was here. And he said, look at him now, laughing his head off. And I thought, oh my goodness, that's the difference. Even a plasterer that's come into the house can see the difference this has made to Matthew in terms of his agitation and his well-being. And the irony of it all, although it took me a big fight to get it, I costed it all out in part of the process, trying to justify getting the budget to employ carers ourselves. And I think the saving is at least £50,000 a year compared to sending him to college, to transport, to this, to that, everything else that the kind of standard offer would have taken. I think we've actually saved £50,000 a year that comes out of the public purse. And also there's other savings as well because of, I think we micromanage the budget, whereas if it's managed by a big healthcare system, sometimes the person making decisions is very far removed and doesn't see what's happening on the front line. And we see every day where every penny goes. And I think most other families are like that as well. They know how precious this is and they're very careful.
Yeah. And so you spoke about a shift in how we do things and how that change can take a while to be set in place. And talking about change, you recently took a break from your job as a pediatrician at Great North Children's Hospital in Newcastle upon Tyne to train for and participate in the Clipper Around the World Yacht Race in
Yes.
2026. And it's a 10K Seattle, Panama, Washington, D.C., Oban, Scotland, and Portsmouth, England route here. So to wrap up this episode of Mapping Healthcare, tell us a little bit about this experience that someone like me who's new to the world of yacht racing should know about.
Yes. So I think 32 years as a paediatrician, 25 years looking after Matthew, I was exhausted, as you can probably understand. And I realised I needed a break and I wanted to do something for myself. My youngest has just graduated uni. And I thought this was the right time because of, Matthew being a wheelchair user, we've been unable to do lots of things that I would have wanted to. And at times, to be quite honest, felt really sorry for myself that I'd missed out on a lot of things. And I thought, right, I'm now at the time of my life I can think about what is it that I feel I've missed out on. And rather than feeling sorry for yourself, do something about it. And yachting was one of them because, getting a wheelchair onto a boat or yacht, I'd done a little bit of it when I was younger, always wanted to do more and haven't because of work and the children. So that was a big thing for me. And I thought, yeah, I want to learn to sail. And I went from that. And rather than doing like a short holiday or weekend course, I thought, no, I'm going to go big. And I knew about the Clipper Around the World Yacht Race, which is the only open ocean race where non-professional sailors, so people who just do it as a hobby or want to learn, can actually participate. So for the last 2 years, I have been training with Clipper and have been doing a lot of things to get fit and have got through all the training. And I'm now on one of the crews and I'm doing the last quarter of the race, which is, as you said, is Seattle to Washington via the Panama Canal and then across the Atlantic back to the UK. 10,000 miles. It'll be 3 months of my life on a very small 70-foot boat with a crew of other people in not luxurious facilities, I must say. We work in 4 and 6 hour watches. So doing many years of pediatric on call has been good preparation for this sleep disruption and deprivation. And that I cope fine with, as has been a mum of 3 kids. Physically, it's all, we hoist the sails by hand. We get them up on deck by hand. There's no electrical buttons that you push that just does things. It's all very physical. And we have to work as a team very closely to support each other and to get the boat sailing and race. It has been the hardest thing physically and mentally I have ever done. I really underestimated how hard it would be. But I've cried at points and thought of giving up twice during training, and then have picked myself up and got on with it. And it's been a really amazing experience and a massive challenge, but it has been a brilliant thing to do and to learn about, and just to do something different and have a refresh away from the family and work. And hopefully we'll come back in July next year, refreshed, reset, and back to pediatrics.
That sounds like a really challenging experience, but you clearly have the resilience and courage to go on with it. And, you mentioned an important part of being a family member of a person with complex disabilities or any chronic medical condition, right? Trying to take that time for self-care so you can reset and come back with renewed energy. Those are all the questions I have for you, Helen. It was such a pleasure talking with you and reconnecting with you.
Thank you. Thank you very much for asking me.
So that was Dr. Helen Leonard telling us about how and why health systems frequently fall short for people with complex medical needs. With all these massive challenges, how can the health system do better? The answer seems to lie in moving away from a really fragmented health system to one that's much more integrated. On the one hand, you've got the fragmented system that so many families are stuck in. Clinicians who don't talk to each other, doing the same tests over and over again, medical records that aren't available when you really need them. On the other hand, you have the goal, integrated care, something that's coordinated, that's centered on the whole person, and that's way easier to navigate. And when we get this right, the benefits are huge. With integrated care models in the United States and in other countries, families say that they get way more individualized attention. The whole system is easier to get through. Care coordinators help manage care, and communication and data sharing is just better. Helen told us a little bit about the personal health budget that Matthew gets from the NHS. This is money for people with complex health needs to manage their care and support in a personalized plan. The United States doesn't have a single universal personal health budget, but it does have a similar concept called self-directed services for people with complex needs. And the level of coverage varies based on the Medicaid program of the state that you live in. Integrated healthcare is not a simple fix. There's some pretty big barriers. Financial incentives are aligned more with the volume of care rather than its value. Health records often don't get shared between different physicians or different health systems. There's a lack of stable funding and real trouble linking up healthcare with the school system or social services. So while the system is slowly getting better, caregivers are basically forced to find their own strength, harness support from their own network, reframe their expectations, and adapt to a totally new normal. Parents say it's about finding joy and making memories with their loved ones, even when the circumstances are extreme. It's bringing suction equipment to the beach because that's what you sometimes have to do for your kid. So where does this all leave us? What's the path forward here? One issue is that studies on integrated care models need to include the voices of the children and their families from the start. Even when we have the best intentions, we might be completely missing the most important perspective of all. If you want to truly help these kids and help integrated, coordinated care models thrive, you have to support the entire family. Because caring for the caregiver is caring for the child. You simply cannot separate the two. The first step to truly caring for children with complex medical needs isn't some new technology or a fancy treatment. It's simpler and harder than that. It's about learning how to truly see, support, and care for the people who are fighting for them every single day. Thanks for tuning in. This was your host, Dr. Sheikh. You were listening to Mapping Healthcare on KDRT 95.7 FM. Please connect with the show on Instagram at Mapping Healthcare to share your thoughts and ideas for future episodes or guests. You can hear Mapping Healthcare around the world anytime on kdrt.org and wherever you get your podcasts. If you enjoyed this episode, please don't forget to subscribe and leave a review.